Good morning. At the outset, I wish to thank the organizers for making me the opening batsman and kick-start what certainly promises to be a unique conference. My sincere apologies for not being able to be present there physically due to some unexpected developments. Most of the problems in life, ladies and gentlemen, are because of two reasons. We act without thinking, or we keep thinking without acting. Wise men speak because they have something to say. Fools because they have to say something. In the next 900 seconds you will decide into which category I belong. Complication in neurosurgery is an unfavorable evolution or consequence of an intervention, usually iatrogenic. The disease can become worse in its severity, showing new signs, symptoms, or pathological changes. Surgery itself may produce adverse effects. Medical knowledge about a disease, procedure, or treatment usually entails a list of the most common complications so that they can be foreseen, prevented, or recognized more easily and speedily. Depending on the stage of the diagnosis, the complexity of the condition per se, and of course the presence of comorbidities, complications may occur oftener. The term complication itself connotes that the resultant condition complicates, makes the management of the causative condition much more complex and challenging. Neurosurgery, contrary to what most of us would like to believe, is still in 2017 often an imperfect science with constantly changing knowledge, uncertain information, and fallible individuals. In spite of the evidence-based medicine which we all talk about, habit, intuition, and sometimes just plain old guessing is still used. In a recent study, Harvard Business School documented that emotional intelligence or gut feeling decisions were taken by Fortune 500 CEOs, resulting in major mergers and acquisitions, not on statistical analysis of big data. Yes, it is unreasonable to expect perfection, but certainly it is not unreasonable to expect us to always aim and try to achieve perfection. I would like to quote what Atul Gawande said in one of his publications. This was not guilt. Guilt is what you feel when you have done something wrong. What I felt was shame. I was what was wrong. This, I think, is the most important thing. Having been in neurosurgery for more than 4 decades, I would like to do some introspection. Now, as a senior citizen with white hair, calling upon judgment, tolerance, and wisdom which hopefully I learned over the last few decades. First and foremost, if you must play, decide upon 3 things at the start: the rules of the game, the stakes, and most important, the quitting time. There is no role for ego whatsoever. It is better to have lost a battle in order to win the war. All of us make mistakes, but only fools repeat these mistakes. Knowledge is learning from your mistakes, but I would like to be wise and I would like to learn from the other man's mistakes. Even worse than losing self-confidence is reacting defensively. There are surgeons who will see faults everywhere except in themselves. They have no questions and no fears about their abilities. As a result, they learn nothing from their mistakes and know nothing of their limitations. As one surgeon told me, it's a rare but alarming thing to meet a surgeon without fear. Again, a quote from Atul Gawande. There have several books written on complications in surgery alone, but interestingly, I was not able to come across conferences dedicated for complications in neurosurgery. Now let's quickly review the literature before I share with you my personal experiences in the last couple of decades. gamma knife radiosurgery for arteriovenous malformations. Having started the first stereotactic radiosurgery unit in South Asia in 95, I was actively involved in the use of stereotactic radiosurgery, and of course I have had my due share of complications. The landmark paper by Majid Sami, Management of 1,000 Vestibular Schwannomas, particularly emphasizing on complications. However, not much is spoken about this paper, which throws a totally different light, a patient's perspective on acoustic neuroma, subjective assessment of symptoms, diagnosis and therapy. It is very interesting that the perception of a patient on what is a complication is quite at variance from that of the primary surgeon. The word complication therefore connotes different meanings for different people and at different points of time. One has to learn to look beyond technology and surgical expertise. The advances in the last 15 years probably have been more than in the last 100 years, and believe me, the advances in the next 5 years are going to be much more than in the last decade. Obsolescence is the name of the game. Fundamentals are being challenged. Expectations of patients have become an all-time high. What would never have been considered a complication 2 decades ago will certainly be considered one now, and even more so tomorrow. Just as one must be aware of complications, it is equally important that we unlearn many surgical techniques which were part of the dictum even a few years ago. Unlearning is as important as relearning. Complications, essentially, many complications can be prevented. This implies an innovation of a mid-course correction. Respond, do not react. There is a difference between reacting, a knee-jerk reaction, and responding to a situation, analyzing all the information that is available. True delegation. I think this is very important. One must learn to delegate, not necessarily to your seniors, but to people far junior to you. Giving up something to a colleague, this is real delegation. At the end of the day, I know certainly that a lot of complications could be avoided if I hand over this particular surgery to a colleague of mine rather than do it myself. And finally, ladies and gentlemen, do the job you hate the most. All of us love to do the job we like, but doing the job you hate the most. Practice makes perfect. We are what we repeatedly do. I am quickly going to run through a few complications which I have encountered over the last couple of decades, just to give you an overview, as it were, of general neurosurgery. Now, this was a patient deeply comatose, operated in a government hospital in the middle of the night, and to our horror, the next day he developed a massive bleed inside the decompressed area, and then we realized that this was a case of disseminated intravascular coagulopathy. We did not do the necessary hematological tests. Perhaps the conditions were attenuating enough, but then there is no excuse to explain to the patient. An acute subdural hematoma, post-shunt, post-posterior fossa SOL excision. How could I have prevented this acute subdural from occurring? Yes, these were all done in the 20th century, but nevertheless, these are things which one encounters even now. Massive pneumocephalus, not intended at all. Multiple aspiration of brain abscesses, and in those days, of course, this was a treatment of choice, and here you see that air is now acting as a problem, replacing the pus which we had. Infarction occurring after surgery. How could I have ever prevented this? Perhaps not. But to a patient, the lack of improvement, the persistence of the neurological deficit, in spite of surgery being done, I cannot explain to him that, look, this is not my mistake, a vessel shut off, and therefore the whole area of the brain got infarcted. So these are things which you need to decide whether you are going to tell the patient earlier or not. Here is a patient whom I will never ever forget. alert oriented, a few drops of CSF coming from his nose, a closed repressed fracture. This was entering into the air sinus. He was not particularly worried about cosmetic disfigurement, and we decided not to surgically intervene. But to our horror, he developed a fulminant meningitis, and in spite of all the antibiotics available at that time, we lost him just because of intractable meningitis. Is this a complication? Could this have been avoided? Should I have started prophylactic antibiotics on day 1? Yes, we did culture sensitivity later, but perhaps it was too late. Now, I would like to call this as an example of minimally invasive surgery. Here is an example of how complications need to be foreseen and how they could be prevented. Here is a patient on the first left-hand side. You see bifrontal contusion, neurological deficit not too much, about GCS about 13. On day 2, obviously the clinical status deteriorated. We repeated the CT, found an increase in size of the hemorrhagic contusion, and we decided to operate. But based on the location of the lesions, bilateral, I decided to do the minimally invasive surgery, not to be too heroic and not to try to evacuate the entire damaged brain. This was a deliberate decision taken, and 25 days later you can see the post-op CT, the contused brain which was left behind has totally resolved, and the patient was discharged without any neurological deficit, excepting of course for the bilateral craniectomy defect, for which he had a cranioplasty later. As neurosurgeons, we always think that complications are referable to the nervous system. Complications can be systemic, can involve multiple organs in the body, particularly when there is prolonged unconsciousness. Perhaps these were photographs taken in 2003. Perhaps much better nursing care today makes such photographs rather rare, but nevertheless you can see other complications including like malnutrition, edema, bedsore, and you can see how a wound has broken down. A craniotomy wound has totally broken down, added with mild infection and so on. A pseudomeningocele, a cervical pseudomeningocele, probably the dura had not been closed, watertight, and this was what has happened. What is the point in removing a tumor very well, no neurological deficit, if the patient comes back to you with a large swelling which had to be aspirated several times before it finally settled down? Yet another example, could this be called a complication? This young man was admitted for a minor head trauma with no neurological deficit. A few days later, he developed weakness of the limbs, and to our horror, on investigation, we found he had developed a cervical extradural hematoma, which further investigations revealed probably was secondary to a disseminated intravascular coagulopathy. Of course, he had a cervical laminectomy done, the EDH was removed, and the patient recovered completely. But nevertheless, this could be called a complication. I have had at least 3 instances where after angiographic demonstration of total obliteration of an arteriovenous malformation, 2 years, 4 years later, the patient has developed a hemorrhage. This is now well documented in the literature. Here again is an example of an MRA demonstrating a CTA, demonstrating total obliteration, but nevertheless the patient has a cyst in the area where the AVM had originally been present and where we had irradiated. Yes, the cyst at present is asymptomatic and nothing was done for the patient. Would this be called a complication? Do you need to explain to a patient before you do radiosurgery for an AVM that this could happen? Do you need to tell a patient with an acoustic schwannoma that there is a very, very small chance of a malignant transformation occurring decades later? Here is an example of a chronic extradural hematoma, a chronic calcified subdural hematoma. The subdural hematoma occurred, or rather was detected 9 years after the initial boreholes were made for evacuation of the SDH. The chronic EDH was detected several months later. Would these be termed complications? How does one manage this? Here again is an example of a large basal meningioma treated with stereotactic radiosurgery, shunt done for the hydrocephalus, and post-radiation scan shows considerable regression of the meningioma and a very small SDH post-shunt induced of no clinical significance. I would like to conclude my talk that treatment of complications is not the correct approach. The ideal thing would be to prevent complications in the first place. Here is an example of a patient with an intracanalicular adenoma who I am sure many members in the audience here are capable of operating, maybe even preserving hearing, but a conservative person like me, I decided to follow up the patient and decide on intervention, whether it be radiosurgery or otherwise based purely on audiological findings. 20 years follow-up has been done. The adenoma has not grown, nor has there been any progressive hearing loss. Another example of a cavernous sinus meningioma and image diagnosis, again followed up for 19 years. The persistent lateral rectus paresis which this young girl had when she first came to me is still persistent, but no new neurological deficit has developed. Visual acuity and fields continue to be normal. Maybe there are surgeons who would have operated on this patient, perhaps there have been no complications as well, but for the majority, the average neurosurgeon, the chances of complication would definitely have been higher. So ladies and gentlemen, what is the take-home message? The take-home message is, our greatest glory is not in never falling, but in rising. The only way to avoid complications in surgery, as Bailey and Love had mentioned in this 1968 book which I first read, is to avoid surgery completely. Complications will be there. I would like to conclude by sharing with you an incident which happened to me in 1995, though this photograph was taken 7 years later. I had started the first radiosurgical treatment planning procedure in the country, and 2 weeks later, to our horror, the treatment planning system did not work. We tried everything, we made a call to the physicist in Australia to help us, etc. And it took us several hours before we realized that one of the cables coming to the planning system had been nibbled away by a rat. We had not anticipated the presence of a rat. And what was the treatment? Of course, we started off with a rat trap, but keeping in line with sophistication, we got an electronic rat detector so that there would be no rats there. This was what we learnt in 1995. Today, perhaps it does not hold good, but please remember that there is no way you can totally avoid a complication. One must be prepared and ready for it. So, in conclusion, the ideal neurosurgeon in 2020 must be a superman. He must be a combination of Shushruta, whom the world recognizes as one of the greatest surgeons. He must have the compassion of Mother Teresa, the pragmatism of Lord Krishna, so beautifully enunciated in the Bhagavad Gita, the genius of Albert Einstein, the innovativeness of Steve Jobs, who brought the iPad to us, and this alone will result in a superman. So, I do not think it will be ever possible to totally avoid complications, but once we understand that each individual is different, evidence-based medicine has only limitations, we must be prepared. Forearmed is forewarned, prevention is better than cure. And most important, it is necessary that in spite of the technical expertise which all of you have developed, we never ever forget to talk to the patient, to the family before the procedure, and if a complication does arise, be absolutely honest, explain to them. Scientific data has revealed that malpractice suits are filed against doctors not because of the complication per se, but purely because the doctor had not spoken about this in detail, honestly and frankly to the patient and the family. So communication is as much an art and a science, and I am particularly happy that KK Turel has taken this fantastic step of getting together people from all over India and the world to discuss what really happened in their own personal life, and I wish the conference all success, and once again I apologize for my inability to be physically present there. Thank you, sir.